Welcome to the second part of Nutrition 2. This is feeding disorders. Feeding plays an important role in the parent-infant relationship. It involves an interaction between the child and the caregiver. Feeding disorders is a severe problem that results in substantial organic, nutritional, or emotional consequence. It may present as food refusal or lower amount of food intake than the appropriate for age due to behavioral issues or underlying organic conditions. It can be isolated. It may present as negative behaviors during feeding and concomitant disorders within an organic disease. They can be termed as limited feeding, selective feeding, fear of feeding, and problems in feeding styles. Studies have shown that 25% of children have feeding problems, and 20 to 25% have mild feeding problems and misperceived problems, while 1 to 5% have true feeding disorders. It occurs in 30% of preterm infants, up to 80% of patients with neurologic impairment or developmental handicaps. What are the 5 key elements in evaluation? How is the problem manifested? Is the child suffering from any disease? Are the child's weight and development being affected? What is the emotional climate like during the child's meals? Are there any great stress factors in the family? These should be considered. Feeding disorders may present as prolonged meal times, like food refusal lasting for 1 month, disruptive and stressful meal times, lack of appropriate independent feeding, nocturnal eating in infants and toddlers, introducing distractions to increase intake, prolonged breast or bottle feeding in toddlers and older children, and failure to introduce advanced textures. Feeding disorders may manifest as limited food preference, pocketing of food in cheeks, spitting food out, weak sucking or chewing skills, slow progression to table food, and gagging of lumpy or chewable food. In the approach in identifying feeding disorders, usually a parental concern, aberrant behavior, or inappropriate feeding is the chief complaint. With a good history, review of systems, accurate anthropometric measurements, and appropriate physical exam, you can determine organic red flags as well as behavioral red flags. These are the pediatric conditions associated with feeding problems and feeding disorders. For the organic red flags like prematurity, genetic or chromosomal abnormalities, craniofacial anomalies like Pierre-Robin syndrome, and cleft palate. Also consider acquired brain impairment like cerebral palsy, gastrointestinal disorders like gastroesophageal reflux disease and constipation, neurodevelopmental disorders like autism, spectrum disorders, and global developmental delay. Children show incorrect feeding behaviors without underlying organic diseases in behavior red flags, but behavioral problems may coexist and often added to the chronic organic problems. The most serious complication of these behavioral red flags is failure to thrive, growth faltering secondary to poor caloric intake. Our primary concern is the identification of children whose poor appetite is due to underlying organic disease. Further investigation for the specific organic etiology in mind will be necessary in order to address the problem. However, in children with no organic disease identified, we should consider the following types of feeding difficulties, like limited appetite, selective intake, fear of feeding, and feeding styles. In parental misperception, the primary risk for these children is the excessive parental concern that leads to coercive feeding methods that may adversely affect the child. Provide parent education, appropriate expectation for growth and nutrition, basic feeding practices, feeding guidelines, importance of not using force or coercion. Lessen parental fears about nutritional inadequacy. In the limited appetite, specifically energetic and active child, a maximum of 5 meals including snacks per day with nothing but water in between. It is important to minimize distractions during feeding. If growth failure is associated with poor appetite, you may need to increase the caloric requirement and addition of nutritional supplements. Here are the descriptions of these feeding problems as well as their management. For the limited appetite, apathetic, and withdrawn child, they may be inactive, disinterested in both eating and their environment, so provide adequate nutrition. If they fail to make eye contact, babble, or talk, make use of supportive interaction with an experienced feeder. If malnutrition is evident and a disorder of reciprocity is described, sometimes this necessitates hospitalization to provide positive feeding environment. For the, selective intake misperception, manage by educating parents and counsel them to repeatedly expose children to new food. It must be offered 8 to 15 times without pressure to achieve acceptance. For the mildly selective child, these are the picky eaters, educate parents and counsel them. Hiding pureed vegetables in sauces, using dips to enhance flavor, give food with appealing names, involve children in food preparation, and present in attractive designs are some of the management for this type. For the highly selective child, these are diet with less than 10 to 15 types of food, and consistently refuses specific food due to taste, texture, smell, or appearance, with sensory food aversion. It can be managed by explaining parents that the feeding difficulty is part of a broader sensory condition. Like 90% of children with autism have feeding problems classified as highly selective. In more severe cases, altering the taste, color, texture, and exposure to food, also known as fading, and shaping can be done. For food chaining, like for example, you give fried chicken, so the next is you can give grilled chicken, then maybe chicken adobo, chicken afritada, then going to chicken tinola. If you want to give the child another food group, for example, the child's favorite is fried chicken, maybe you can give chicken nuggets, then going to fish nuggets, then grilled fish. These are the forms or shaping of food for the highly selective child. Fear of feeding, usually after a single event like choking, after being subjected to painful and unpleasant oral procedures, who are tube fed, can be managed by reducing anxiety associated with feeding or eating. Reassurance is the key to recovery with positive reinforcement, and in severe cases, cognitive behavioral therapy may be necessary. For the These are the different feeding styles. For responsive, which is ideal, they follow concepts of responsibility. The caregiver guides the child's eating habits, sets the limit, they model appropriate eating habits and behaviors, and talks positively about food. For the controlling type, this is the common form in care among caregivers. They use force or punishment or inappropriate rewards to coerce child to eat. For indulgent, the caregiver feeds the child whenever and whatever the child demands. This may result in lower consumption of appropriate food. For neglectful, the caregiver abandons responsibility of feeding the child. The parents ignore the child's hunger signals and other emotional needs, and in severe case may result to failure to thrive. For the management, explain and help parents to be responsive feeders. Controlling parents should be guided to offer food in non-coercive way. For indulgent and neglectful parents, they should be more structured and precise. If left poorly managed, these feeding problems can be a hindrance to good nutrition in children. This is the end of part 2.